This presentation will focus on the geriatric syndrome of falls. Geriatric syndromes are often multifactorial health conditions that occur when the accumulated effects of impairments in multiple systems renders a person vulnerable to situational challenges. Falls should be considered a geriatric syndrome with well-defined risk factors, a specific diagnostic workup, and recommended interventions taking place. The incidence of falls varies among age groups and settings. An estimated 30% of community-dwelling persons between the ages of 65 and 75 years fall annually. This incidence rises to more than 50% in octogenarians and in institutional settings. A key concern with regard to elderly persons is not simply the high incidence of falls, but rather the combination of high incidence and high susceptibility to injury. Although most falls do not cause injury, approximately 5% of persons who fall will require hospitalization. Hip fracture is one of the leading causes of morbidity after a fall, and a significant percentage of patients who sustain a hip fracture never regain their baseline level of functioning. Even non-injurious falls have consequences. Fear of falling and the post-fall anxiety syndrome produces a loss of self-confidence and self-imposed functional limitations in both community-dwelling and institutionalized elderly persons. Falls are the largest single cause of restricted activity during the day among older adults and are a leading cause of nursing home admissions and account for 6% of medical expenditures of persons aged 65 and older. It is estimated that approximately 9,500 deaths occur in older adults each year. With a staggering incidence of falls, the nursing profession must take note. While not all falls are preventable, the majority are. Evidence has shown that a multifactorial approach is key to reducing the number of falls in older adults. This includes reviewing cognitive, medication, and environmental risk factors. For those patients who seek care after a fall, whether it be hospital follow-up or acute care, addressing the potential cause and taking steps to prevent a reoccurrence is crucial. Ongoing evaluation of the patient's fall risk should take place annually or more frequently if indicated. Establishing with the patient a relationship of open communication will break down potential barriers perceived by the patient to open up about their risk of falls. The patient chosen for this presentation was seen in the clinic for an acute illness. He currently does not have any allergies. Medications that he's on include Dexilant, Norvasc, HCTZ, Lopressor, Metformin, Lipitor, and Zoloft. He was up to date on his immunizations and health maintenance, such as annual care visits, colonoscopy, AAA screening, annual laboratory reviews for his diabetes, as well as his high cholesterol and hypertension. Past medical history for him is diabetes mellitus, hypertension, hyperlipidemia, angina, anxiety, and GERD. When reviewing falls, it's important to remember that no presentation is typical. There are risk factors and warning signs that may provide clues for the provider, such as a history of falling, weakness, gait and balance disorders, functional impairments, cognitive impairments, vision and hearing impairments, and the use of multiple psychotropic drugs should all be considered warning signs. For those patients who have fallen in the past, questions regarding the use of walking aids, environmental conditions, and circumstances surrounding the fall should be explored. While this particular patient did not present with any complaints related to falls, often patients will be hesitant to discuss actual or near falls. This reluctance may be attributed to a fear of loss of independence. However, reassuring the patient through open and honest communication that this is not always the case can lead them to open up. At times, those accompanying the patient to their visit, such as a spouse, caregiver, or family member, may be able to provide insight into concerns for actual or perceived fall risk. In addition, possible complaints related to hearing, vision, cognitive, and functional declines, once again, may provide insight into potential or experienced falls. For this patient, his review of symptoms related to falls were negative. However, given his polypharmacy and acute illness, further investigation should take place. During the patient's physical exam, his vital signs were within normal limits, with the exception of his O2 sats being a little low at 94%. His physical exam findings revealed no abnormalities that would relate to his risk of falls. However, careful assessment of the ENT system, his respiratory system, given he is experiencing an acute illness at this time, the musculoskeletal system for his age, and his neurological system, once again, given his age. However, those findings were all within defined limits. The following screening tools were utilized in assessing this patient's fall risk. Activities of daily living, the patient confirmed that he was independent on those. And instrumental activities of daily living, the patient once again confirmed that he completed those independently. With the Tenetti gait and balance, the patient passed that. With the get up and go, the patient scored 15 seconds from rising to the chair, walking 10 feet, returning and sitting back down. With this occurring in around 15 seconds, he's a little bit higher than what we'd like to see, but well within the defined limits of under 20 seconds. However, annual review should take place to monitor for any changes and evaluate the patient's fall risk. Typically with falls, diagnostic exams are not indicated in the prevention of falls. However, for those individuals who have fallen and may have suffered an injury, the following should be considered, such as X-ray, CT, or MRI. Laboratory work may be indicated in those who have fallen to review potential underlying cause or condition. Given the patient's current health state and performance on assessments, no further workup is indicated. Falls can be contributed to a number of causes and conditions, from physical changes related to aging, decrease in muscle tone, pain, and decreased range of motion in one's joints, syncope related to hypoglycemia, dizziness, hypotension, and cardiovascular changes. Medication causing falls are often due to interactions between multiple medications, the use of benzodiazepines, anticholinergics, antihypertensives, Lasix, and glycemic acting agents, etc., all can cause risk for falls. Environmental factors such as rugs, wet surfaces, uneven planes, the use of stairs, and poor lighting can all increase one's risk of falling. With falls being multifactorial in occurrence, a thorough review of potential causes must routinely occur. Through the use of assessment tools that evaluate functional and cognitive abilities, differential diagnoses can be ranked in order of severity. As is the case in the older adult population, and in this patient in particular, there may be more than one diagnosis related to the potential cause of falling. After reviewing the possible differential diagnoses, those of greatest concern for this particular patient included acute illness, polypharmacy, and environmental hazards as evidenced by current symptoms experienced and assessment results. When evaluating treatment for this patient, the treatment of falls should take place both before an incident and after. Since most falls can be avoided, discussing ways to reduce the incidence of occurrence is beneficial. For this patient who is experiencing an acute illness, education on frequent periods of rest and adequate hydration may help reduce his risk of falls associated with pneumonia. Further education regarding his daily routine would include reviewing the use of medications he's on, such as the antihypertensive, diuretic, and metformin, which have the potential to cause hypotension, decreased blood sugars, leading to dizziness and a subsequent fall. In addition, the patient is considerably active and spends time outdoors. Being aware of his surroundings, such as the placement of tools while he's working, uneven surfaces, climbing, and lifting heavy objects, will help eliminate potential falls and injury. Continued routine assessment at biannual visits will provide insight to the patient's current gait, balance, and stability. While no urgent or areas of concern are present at this time, ongoing evaluation is warranted. For those patients who may have experienced a fall in the past, an interdisciplinary huddle is advised to identify potential causes and areas of intervention. It has been documented that patients who have experienced a fall often have a lingering fear of falls, leading to a decline in function. With evidence showing prevention as the key to reducing the rate of falls, examples of interventions include the use of Tai Chi, vitamin D treatment if indicated, and a medication review. Adherence to treatment guidelines and preventive measures in this patient will be a lack of willingness to ask for or accept help when needed. This patient in particular is extremely stoic and tends to push himself beyond what are deemed safe limits for his age. Addressing with him that asking for and utilizing helping services is not a sign of weakness will be key in his recovery and continued health. While further resources and referral are not indicated at this time for the patient, it is important to be aware of what services are readily available to patients who are at risk for or have experienced a fall. An annual physical and screening is covered by the majority of health insurance companies, including Medicare. Of interest is patients who obtain or have Medicare Part D are allotted a 30-minute appointment time with a pharmacist for medication review. This may reduce the risk of polypharmacy occurring in older adults. Patients who may be experiencing joint pain should be referred to a specialist for further intervention, as increased pain may be associated with instability and higher levels of medication use, subsequently leading to a fall. Services that are available in this community for the patient and those who are at risk of fall, and these services are often paid for by Medicare if deemed necessary, include home health, who can assist with bathing, toileting, dressing, and simple housework, physical and occupational therapy to regain lost strength and improve independence with daily tasks. These services can often be provided in-home, reducing the excuse or lack of transportation. In addition, community resources available include meal delivery services and medical transportation services at low or reduced cost to older adults. Health behaviors and detriments identified related to falls in older adults include the belief that falls are an inevitable consequence of aging, while others believe it won't happen to them. In order to overcome the perceived inevitable or negative connotations associated with the topic of falls, early discussion and assessment should take place. Implementing key factors such as social support, low-intensity exercise, and discussion that such assessments and lifestyle behavior changes have relevance are critical in making lasting changes. In the case of this patient's behavior and barriers, potential risks include denial of his risk, no previous history of exercise. In order to engage the patient in participation, changes will need to be presented as lifestyle enhancing and a way to remain his independence. Ongoing encouragement, support, and education will be needed for this patient. There are currently no identified socioeconomic, cultural, ethical, or legal issues for this patient. Continued observation of the patient should include current or potential concerns for long-term financial and social stability. By utilizing and referring to community resources for the elderly, potential adverse events related to a fall may be avoided. While completing this assignment, I have been able to experience firsthand the importance of early screening and frank discussions regarding falls in the older adult population. Future considerations to learning include use of correct assessment tools, appropriate screening guidelines, and testing. In regards to personal learning and practice, it is critical for the provider to stay abreast of new research and trends to improve the health of the older adult population, specifically those regarding geriatric syndromes.